It's always a delight to welcome Morag Taylor. So I've worked with Morag now for over 18 years. Seems just like yesterday. So Morag's a research fellow at Neuroscience Research Australia, and she's recently started with us in the registry as our data analyst. So that's been a very welcome position to have filled. She's a physiotherapist by background, worked in the rehabilitation setting at the Prince of Wales, then transitioned to do a PhD and abandoned public service.
I was led astray.
And as a nice follow-on to Sue's presentation, Morag's research interests are purely around rehabilitation for those with dementia, both understanding and trying to come up with interventions to improve outcomes for older people with dementia. So Morag is going to be talking about the ANZHFR data and what it's actually telling us. So thank you, Morag.
Okay, so this is when I wish I was a bit taller, but unfortunately I can't help genetics. So it is a nice follow-on from what Sue just said. So my interest is in dementia, and so I wanted to look at what are the differences in care and outcomes in the Australia-New Zealand setting for people with and without dementia. So let me see, is this going to work? Yep. So we've used the hip fracture registry data, and we've used the data from 2016 to 2022. We've looked at those who are over 50, and just to say that the number of hospitals contributing to the registry obviously increase over time. So we started with 87,000 records, and I specifically wanted to look at people who had a surgical repair, so we've got close to 85,000 records, and then to compare people with and without cognitive impairment, we needed to have a known cognitive status, so where the final population is 81,506. And I wanted to compare the care provision and outcomes for people with and without cognitive impairment who have hip fracture surgery. So I'm going to sort of race through some of these early slides so I can talk a little bit more on the later slides, but I'll just orientate you to the slides. So in all of the slides, cognitively impaired are blue and cognitively healthy are green, and on the left-hand side on the y-axis is the percent of the population. So what we can see here is that the cognitively impaired people are significantly older than the cognitively intact people, but there's no difference in sex. Cognitively healthy people are more likely to come from private residence, and cognitively impaired people are more likely to come from residential aged care facilities. And cognitively impaired people have poorer pre-admission mobility, so you can see a high proportion are using two aids or a frame, whereas the unaided is the highest proportion in the cognitively healthy people. In terms of if we use the ASA grade as a sort of a general marker of health, you can see that cognitively impaired people have poorer health overall, with more of them in the category 4 and category 3. And they're more likely to be frail. So this is the proportion that are moderately frail or worse. So we've got over 70% of the cognitively impaired group who are frail. And in terms of malnutrition, so this is for Jack. So the cognitively impaired group are more likely to be malnourished, but you can see we've got some improvement to make here because there's still about 30% of the population who actually aren't being assessed. And then I wanted to see, well, have we gotten better over time? So this is just looking at those who are assessed, and this is the proportion of people who are malnourished, and you can see it's fairly steady across time, and there's more than, of those assessed, more than 40% of the cognitively impaired group are malnourished. In terms of the type of surgery, so the cognitively intact people are more likely to get a total hip replacement, and the cognitively impaired people are more likely to have fixation or a hemiarthroplasty. And along with that, I haven't shown here, but the consultant is present more often for the cognitively intact group, probably because they're having more total hip replacements. In terms of surgery within 48 hours, there's no significant difference between the two groups, so that's encouraging. And then this is where things start to take a downward turn. If we look at the proportion of people who are offered to mobilise on day one, you can see the cognitively intact group are just over 90% and the cognitively impaired group are just under 90%. So I was like, oh, that's pretty good. But then with the variable that was introduced in 2020, you can see that the proportion of people that actually achieve walking on day one is just under 60% for the cognitively intact group and just over 30% for the cognitively impaired group. Okay, so then I wanted to see, okay, well, maybe we've improved over time. have we gotten better over time? But unfortunately we haven't, and actually 2022 looks a little bit worse over time. So then I said, okay, well maybe it's because there's more people with cognitive impairment coming from residential aged care. Maybe that's the solution. It's the setting that they're in, not the population. So you can see here, this is on the left, there's the community group, and on the right is the group from residential aged care. And it doesn't matter whether you're from the community or residential aged care, if you've got cognitive impairment, you're less likely to walk on day one. So then I would have a look at the acute ward discharge destination. So along the bottom you can see there's private residences first, residential aged care facility, and then rehab, public and private, and then the other less common there. But so if you're cognitively healthy, you're more likely to go home. It's quite surprisingly, so these are people who are admitted from private residences. The difference between those who go to rehab and don't go to rehab, if you come from the community with and without cognitive impairment, when you add the private and public together, is significantly different, but it's probably not clinically significant. There's only about 2% difference between the two. So I was quite encouraged by that. You can see that more people with cognitive impairment die. And then this is the group from residential aged care facilities. So you can see if you're cognitively impaired, you're much more likely to go straight back to the residential aged care facility, which is similar to what Louise described. But if you're cognitively healthy and from a residential aged care facility, you're more likely to get rehab than if you're cognitively impaired. So it's not got to do with the setting, it's got to do with whether you're cognitively impaired or cognitively intact. And I do understand there is a strong belief to try and get people who may become confused back into their usual environment, but there does seem to be a difference between the care we're giving to people with cognitive impairment. So this is looking at hospital discharge destination. And again, it's a similar story. If you're cognitively impaired and you're from the community, you're much more likely to go to residential aged care facility. And if you're from residential aged care facility, most of you go back to residential aged care facility, but it's more so for the cognitively impaired group. You can see, I don't know whether there's been a coding issue with the people from residential aged care going home or whether they were in respite. We don't have that level of detail, but some do go home if they've come from residential aged care facility. Okay, so this is looking at length of stay. So at the top is the acute length of stay if you come from the community. And you can see that the cognitively impaired group have a significantly longer length of stay if you come from the community for the acute care portion of their admission. If you come from residential aged care facility, there's a significant difference, but it's not clinically meaningful in terms of the median, but when you look at the interquartile range, the cognitively healthy actually stay longer. And then if we look at the overall hospital length of stay, if you come from the community, the cognitively impaired group actually stay longer. And if you come from residential aged care facility, the cognitively impaired group have a shorter length of stay. And this likely represents that difference in rehabilitation practices, where the cognitively healthy group are more likely to be offered rehabilitation, which means their hospital length of stay is longer. So then if we look at delirium, so this is another area where we can improve on actually assessment. So you can see that there's still about 30% of people not being assessed. Encouragingly, this is less common in people with cognitive impairment. But of those assessed, if we look on the right, you can see that more than 65% of the cognitively impaired group are diagnosed as having delirium, compared to just over 20% of the cognitively healthy group. New pressure injury, so these are small numbers, but there is a significant increase in risk of having a pressure injury if you have cognitive impairment. Maybe that's related to not getting up. We don't know from this data. And then if we think about the people who came from private residence, where did they end up? And this is excluding people who died and people who went to other, so just comparing home versus residential aged care facility for people who came from private residence. You can see that there's 10% of cognitively healthy and more than 45% of the cognitively impaired group are newly transferred to residential aged care facilities. Okay, so now I'm going to confuse you with some of these complex models, but this is just to show you, I'm going to pick out the bits that are important here, but so we're adjusting for age, sex, how you walked before you came into hospital, your ASA grade, fracture type, surgical fixation type, and then we're looking at factors that are associated with discharge to residential aged care facility, so a poorer outcome, compared to those who go home. So if your time to surgery is greater than or equal to 48 hours, you've got a 16% increase odds of ending up in residential aged care facility. If you're not offered mobility, you've got a 16% increased chance of odds of ending up in residential aged care facility. If you have delirium, you've got a 93% increase odds. If you've got known cognitive impairment, so this is similar to the previous slide, you've got a 4 times the odds of ending up in residential aged care facilities. And if you receive rehabilitation, you've got a reduced odds of ending up in residential aged care facility. So Jackie and I argue over this. I like to think that it's the rehab, and Jackie likes to think it's the type of person who ends up in rehab. And it's probably somewhere in between. It's probably a mix of both is what I feel like. But I've tried to, I'll come to the next slide, and I've tried to tease out that a little bit more. So this time, the variable whether you achieved first day walking was only introduced in 2020. So this is a smaller population because I've only included that data. But again, you can see that time to surgery increases your risk, increases your odds of ending up in residential aged care facility. If you do not walk on day one, you've got a 78% increased odds of ending up in residential aged care facility. And delirium, cognitive impairment also increase the odds in this model, and receiving rehab reduces the odds. Okay, so on this slide, this is just in people with cognitive impairment, and I've adjusted for all those other things. I've just put a small portion of the table on this slide. So this is only in people with cognitive impairment. And what you can see here is that time to surgery and not offered day one mobility drops off as being significant, but we've got a much smaller sample size. But delirium still increases the odds of ending up in residential aged care facility. Rehab now reduces the odds by at least half of ending up in residential aged care. So this is where I've tried to tease out, take out some of the bias of the person-based characteristics. And so down the bottom there, the hospital that refers greater than or equal to 70% of people with cognitive impairment to rehabilitation. So the way I've coded that is if in the year of your admission, the hospital that you went to referred 70% or more to rehab, then you were given a 1, regardless of whether you got rehab or not. And so for the people that were attended a hospital that referred 70% or more of people with cognitive impairment to rehab, there was still a 16% reduction in your chance of ending up in residential aged care facility, regardless of whether you got rehab or not, but if you went to a hospital that referred. So that was trying to reduce the bias of the type of person that receives rehab. So I would like to think that getting rehab is still an important component of care for people with cognitive impairment. So then I wanted to look at preserved 120-day mobility, and I looked at the community group on the left and residential aged care on the right, and these are all significant between the community group and the residential aged care group. So people with cognitive impairment are less likely to have preserved mobility to 120 days. And then this is a similar model where we wanted to look at factors associated with poorer mobility at 120 days. And this time we also account for usual residents because it's not just in people from private residence. And again, you can see time to surgery increases the odds of having poorer mobility at 120 days. Not being offered mobility increases the odds of having poorer mobility, delirium, cognitive impairment, and then in this one, receiving rehab increases your odds of not having preserved mobility at 120 days. But this includes the whole sample, so cognitively healthy and impaired, and we know that a higher proportion of the population is cognitively healthy, and they also started off with having better mobility, so a lot of them were unaided. So I think this is because they're likely to get some sort of aid, which means the way we work out preserved mobility, they're not going to have preserved mobility, because even if they're a stick, it's not they're preserved original mobility. And I should say that this is only including hospitals that have at least 70% follow-up for the year that the person was admitted to, so that we're not getting a biased sample. And I've excluded patients who were immobile on admission. So this is the smaller sample size using not achieved first day walking. And again, there's a stronger relationship if you do not achieve first day walking and having poorer mobility. And then I wanted to look at just cognitively impaired people. And so here you can see down the bottom there, if you receive rehab, you've got a lower chance of having poorer mobility at 120 days. So this is where it flips in the cognitively impaired group. So they're more likely to have preserved mobility if they receive rehabilitation. 30-day mortality. So in everyone, cognitively impaired group have an increased 30-day mortality. In the community, the cognitively impaired group have an increased 30-day mortality. And in the group from residential aged care, the cognitively impaired group have increased mortality. So again, time to surgery increases your risk. Not offered day one mobility increases your risk, delirium and cognitive impairment. I didn't put rehab in there because you can't have rehab if you're not alive. 30-day mortality, again, we've got the did not walk is more strongly associated than the offered mobility with 30-day mortality. And so, in conclusion, people with cognitive impairment who fracture their hip are older, more likely to come from residential aged care, they're frailer, they have poorer mobility, more likely to be malnourished, less likely to receive rehabilitation and to walk day one, and they're less likely to receive rehab, particularly if they're from residential aged care facilities. They're more likely to experience poorer outcomes. So they're more likely to have delirium. They're more likely to be transferred to residential aged care facility if they've come from private residence, more likely to get pressure injuries, they're more likely to die, and they're more likely to have poorer mobility at 120 days. So what are the potentially modifiable factors? So we can improve time to surgery, so that goes nicely with the Commission's new standard. We need to get them up and moving. And one thing I missed off there was access to rehab. I think we really need to consider access to rehab and, as Sue said, looking at enhanced care strategies specifically for people with dementia. And as Sue said, currently there's a lack of robust evidence that we can improve outcomes for people with dementia who fracture their hip. So we need to pilot a multifactorial intervention. If anyone's interested, come talk to me. And then we need to trial it for effectiveness and ensure that it's we're able to implement it. So thanks to Jackie and Lara.